Greetings, everyone. Hi, I'm Dr. V. Wish I could see you in person, but here we are, and today we're going to be talking about the ins and outs of your physical exam. This will be your absolute bread and butter as you move forward through this program, so take your time with this. Open this in the notes view and you'll get my notes as well. So this is where you're going to learn the normal from abnormal, and you always compare side to side. So if someone comes in and says that their left foot hurts, you look at their right one first, and they will look at you strange, and you just have to tell them that you're comparing their normal to the one that is not normal for them. So let's dive in. So first of all, you're going to interview the patient. So this is where you get your chief complaint and your data collection, and you establish the rapport. Remember, most of the time they won't remember what you said, but they remember how you made them feel, especially when you're working with folks of hard of hearing or something of that nature. So the chief complaint is why the person is there in their own words. It's usually in quotes, and it's usually pretty short. Quote, sore throat, end quote. Quote, my chest hurts, end quote, something like that. The history of the present illness is where you go in a little bit of a deeper dive as to and you'll use probably old cards, and we'll go over what that looks like, but what's going on, what brought them in, why they're there, what have they tried, what makes things worse, what makes things better, and what they're really trying to get out of the reason or out of the visit today. So usually you begin with that history, but then you proceed into the physical exam. So that's and we'll go over what the SOAP note is. The SOAP note is a subjective, that's what you're doing here. It's subjective from what the patient is telling you. Then you'll get into the objective part of it, which is the O in SOAP, and then that will be what your physical exam will be. And then your A is your assessment. So now you've gotten data from both the patient's words and your own observations. And so what are you going to do about it? And what is your assessment? And then the plan is the P, the last part. So that's what you're going to do. Don't worry, it'll all come together. So when you're done with that, you need to summarize and nail down those pertinent positives and negatives for a better picture. The idea with this HPI, this history of present illness, is that someone should be able to pick this up and get a good idea of what that patient looked like today. So keep that in mind when you're going through it. So super important that you want to really ask about that social history and asking those hard questions. And be careful not to ask, how do you smoke? I see that it says that here. Do you currently or have you ever? Because that's a yes, no. And I always ask the how much are you smoking? Because that is likely to give more information for someone who maybe thinks that you don't want them to say yes to smoking. It's an open-ended question versus a closed-end question. So I ask, how much do you smoke? And then if I get a never smoker and they do I've never smoked, I say, wonderful, that's fantastic, don't start today. And it helps a little bit. So be careful asking those yes nos, because some people view them as judgmental. So just tips and tricks. All right. So with that medical history, don't forget to ask about alternative and complementary therapies. So that's something to work with. When you're asking about illicit drug, especially cannabis or anything along that nature, make sure you advise that answers are confidential and only be shared with other healthcare workers in order to optimize the delivery of care. Okay, so the importance of the interview, especially with the developmental history when you're working with pediatrics, it's particular to the pediatric population. So you want to know, for the pediatric population, the pregnancy, the perinatal care, the birth weight, the birth length, the APGARs, and the developmental history are all part of that. This is also where you're going to start building rapport and teaching, anticipatory teaching, what to expect, especially with new parents at different levels and different levels of development. So health promotion, disease prevention, again, super important. If someone is smoking, then we are to ask them if they've thought about quitting smoking. And if they're not ready, then you put that in there. Same thing with exercise and movement. And then BMI is one of the indicators we use for body weight and seeing if someone is obese or not. It is a flawed system, but it is something that we use, and it is something you'll see more of. So more on that later. Okay, so you are also going to be asking about the mental status and depression and anxiety. You'll typically see the PHQ and PHQ 2 and 9. The 2 is the precursor, that's the first step approach. If that's positive, then you can move on to the PHQ 9 because it's a little longer. At GAD 7, there's only 7. I do appreciate that these particular instruments do tell you how many questions are in the title of them. And then you'll see that postnatal depression screening for evaluating perinatal depression. So one of the things that you're going to be doing is promoting a holistic focus, and that's looking at where the individuals are coming from a a cultural position. So Leininger referred to and defined culture as learned, shaped, and transmitted values between different individuals that are living in a same group that guide their thinking, decisions, actions, and ways of living. You'll hear lots of different terms, but this is the definition we'll be using today, or in this class. Okay, culture can be absolutely complicated to define, and every patient deserves a cultural assessment, not just the obvious patients who are from different cultures from yourself, because there's subcultures within cultures. And achieving, you'll hear cultural competency. I'm not a subscriber to that. I don't believe that you can become competent in all cultures. You can be sensitive, but you can't become competent in all cultures in the world. So achieving that sensitivity is really a process base, and so you'll be learning and becoming more open and sensitive to being and talking to folks from different cultures. So this can be someone coming in with suspicious to you looking bruises, and then they tell you they're engaging in cupping, which is completely a validated way of treating body tension in the back particularly. So be careful not to stereotype, and don't assume that all individuals of the same race and culture or ethnic background behave in the same manner. So just listen to the patient and talk to them about what they're thinking about. So this is really important, especially in healthcare, because it really defines how patients and families are making meaning out of illness and suffering. And it plays a huge role in health decisions, and influences communication, expressions of pain, guides expectation, affects views regarding death. I mean, all of it. So here you see the cultural competency. We're back to the cultural sensitivity. This term changes and has changed multiple times in my career as a nurse, so it's ongoing. The essence is really promoting the value and care of the patient, and it leads to the patient really feeling valued. So it enables us as healthcare providers to become aware of our own prejudices, because we all have them, and knowing that you have them is really the first step into learning how you're going to intake those prejudices and how they affect your decisions moving forward. So you do want to make sure that you focus on, the physical, yes, the emotional. You allow the time for those emotional responses. Try to look really interested and sympathetic. This is hard when you're going in and you're typing on a computer and typing into the electronic medical record. So just be aware of how that is making the other person feel, and talking about the social aspects, that cultural awareness, and identifying the risk status of different patients will help. So what do you think is causing the symptoms? Absolutely is appropriate to ask individuals and listen to what they have to say. It could be really interesting. Okay, so that process of communication, 90% of all that we communicate, maybe it's 85, is nonverbal. So be aware of that. So how you are standing, especially height related to the patients, if you're able to sit down and be at the level, that helps tremendously. And the process really is about sending and exchanging information. There's the verbal and nonverbal parts of this, as well as the receiving. And here are the different factors that you can see that can be influenced by that. So internally, these all influence communication. These are particular to the examiner, so what you bring in. So if you've had a bad day with something else going on and it's written on your face, you're going to walk into that new conversation with that. So be aware of that. So your goal is to not make the patient dependent on you, but help them to be increasingly responsible for themselves. So liking others generally includes that attitude of optimism towards people, acknowledging their strengths. I always tell my patients that they know their bodies better than I ever will. And when something's wrong, they have the right to be listened to. Empathy can be described as feeling what the person is feeling rather than feeling like the person. So see if that makes sense to you. So if empathy is feeling with the person rather than feeling like the person. When you're listening to an individual, it's active. It's an active role. It's not just It's active. And so you're actually asking questions and clarifying questions. Confidentiality is a huge part of what we do as primary care providers, and we need to discuss and often do sensitive topics like illegal drug use. So be sure to advise patients that answers are confidential and only shared with other healthcare workers in order to optimize their care. And there is no need. You'll sometimes feel like you should, but there isn't a need to apologize for asking these sensitive questions because it's part of the job and it doesn't affect the clinical relationship. Okay, external factors. These are particular to the environment. Is the room cold? When you get into doing well women exams, don't have them sitting there in those cold or in those really thin paper gowns while you're trying to do an interview. Have the courtesy to have them get dressed. It's cold in those rooms. So make sure that everyone is comfortable and that it's conductive. So that's where the appropriate dress, minimize the note taking, and then aim for that geographic privacy, so close the door. Sometimes you're in a situation in various clinics that maybe don't have doors, but lower your voice. See if you can talk in a way that is conducive to privacy. Interruptions are absolutely not appreciative. You need to go ahead and concentrate to establish rapport with your patients. So make sure you have enough lighting, make sure the temperature, there's not distraction and noise. If you're in an office that has a window to the outside and you're doing a sensitive exam, make sure the blinds are closed on the window, that kind of thing. So make sure that the patient's appropriately dressed for the exam and draped to conserve modestly. So as a student and as you become a board certified F&P, your name tag should always be appropriately displayed and your attire professional. Some places wear scrubs and that is considered professional attire. So I wear scrubs right now in my clinical setting. So minimize the note taking and especially challenging, like I said, but making sure that you're making those good eye contacts with your patient is really helpful. So you might have to be practicing how you can be typing and looking at the individual at the same time to make sure you get it all down. So communication techniques, open-ended questions, what do you think? The empathy, that silence, that allowing for reflection and clarification. That's where we're talking about avoiding those closed and direct questions, the yes, no's. So you don't smoke, do you? That is a closed and direct question. So be aware of that. Here again, let's see. Yes, empathy, allowing time for the response. Your patient starts to cry. You offer tissue and let them cry. Try to look interested. If you feel appropriate with that, you can ask your individual patient if, they need a minute. And if you need to come back, that's fine. If they want you to sit with them, that's okay too. So just offer some time. So never do this first one, this false reassurance, I promise everything's going to be okay. You don't know. You don't know. You can with confidence say you will try your best to find out what's going on, but sometimes unexpected things happen. So just be careful with that. Giving unwanted advice. It is hard to be in a situation where someone's coming to you for advice and knowing that balance between what they're actually asking and wanting. Using that authority, using avoidance language and distancing. Medical jargon's another one. We as nurses speak in medical terms that not everybody knows, so go ahead and break it down a little bit. Be careful of you talking too much or those leading questions where they think that they know what you want them to respond with. So sometimes it feels like it's quicker just to give advice. So what are the pros and cons of X? It takes time an effort to really get into what is best for that individual. You don't know best, so using that authoritative I know best in this situation, it's not going to work. And it doesn't create a way in which the patient learns to trust you. So using direct language is always better than using the avoidance language, especially when you're talking about loved ones dying. You just got to be careful with that. Okay, so yeah, just be aware of that. So let's see, being aware of using those medical jargons. Okay, yeah, you don't smoke, do you? Talking too much, interrupting or cutting patients off. This becomes difficult when seems like the patient is talking a whole lot. So, and you have a room full of, or a building full of patients. So be aware that that can be a communication trap for you. Okay, and the why questions can also put the person on the defensive because these are the type that imply blame and condemnation. Okay, nonverbal. This is when your posture really takes effect, your gestures, your facial expressions, your physical appearance. Are you interested? Are you there? Are you listening? Are you physically present? Are you emotionally present? So these are those nonverbal skills. You don't have to shake hands with each of your patients when you walk in the door. You can give them a high five, you can give them a nod, just whatever you're comfortable with. Just be sure it's a genuine for you. Okay, developing considerations. So with developmental considerations, excuse me, when your patient's a child, you must build rapport with two people at least, sometimes three or more. So it's at least the child and the caregiver. So nonverbal is even more important to the children than it is to the adults. They're quick to pick up on anxiety and uncomfortable from nonverbal cues. So just be aware of that. Here are the challenges to communication. So be aware. This last one with the language barrier does not mean they're hard of hearing. I often see folks who are trying to communicate in cross languages, and one of them will start speaking louder because they have it in their head that that will help. It doesn't help. So it's a language, not a hearing issue. Okay, so overcoming these barriers, you want to employ that cultural sensitivity, but also includes the gender and sexual orientation. I spent 8 years in Oregon, and Oregon has a different cultural acceptance typically in Portland anyway, which is where I was, than in other areas in the country. And so when you ask about the living situation and gender orientation, it is appropriate to ask, are you sexually active? And are you sexually active with men, women, or both? And so, oh, excuse me, it jumped. Okay, well, I can't go back for some reason, but you can look at that other slide. So this is the, or the rest of it. So in effect, just don't make assumptions about who people are with or what they're doing or that they're in a monogamous situation. Just ask the questions and listen with non-judgment to their answers. So now we'll get into assessment techniques and legal and ethical considerations. So IPPA, this will be something you will absolutely need to know. This is true for every way in which you're going to be doing your exams except for the abdomen. Because, and this makes sense when you think about it, the abdomen you're going to inspect and then you're going to percuss and then you're going to palpate. I'm sorry, you're going to inspect first, then you're going to auscultate and then palpate and percuss. So it's a little bit because if you were to do the palpation and percussion on someone's abdomen, that's going to have a direct impact on their bowel sounds. So keep that in mind. But in general, you're going to do inspection. So you're going to look, and then you're going to feel, and then you're going to see what the timbre of the sound, the percussion is, and then you're going to listen. Okay. So inspection, you're continuously looking throughout the exam. You're concentrated looking, you're smelling, you're hearing. Begins the very first time they walk in the door. General survey, physical appearance, body structure, mobility, behavior. I have patients that are over 100 who don't look it, so I get to say that the individual looks younger than their stated age. So looking. So both visual as well as other senses like we mentioned, and then you're just gathering that data. This is that general survey on gait, affect, the musculoskeletal system, if they have an impairment, if they have a limp, their hygiene, their dress, their dentation, all of that. So not every body region will require the auscultation, but they all require inspection. So learn to use each person as your own control and compare and inspect the right and left sides. I talked about this in the first slide. The two sides are nearly symmetric. So this inspection requires that good lighting, adequate exposure, occasional use of instruments like your otoscope, for example. And then you're touching. You're using a calm, gentle approach, warm hands. I have trouble with this. My hands are always cold. And so I make sure I warn my patients that I have cold hands. I can't seem to keep them warm for my patients. But that applies your sense of touch to assess for factors such as texture, temperature, moisture, organ location, the kidney and liver in particular, and as well as the size, any swelling, vibration, percussion, pulsation, rigidity, spasticity, crepitation. So that's the creakiness in the knees for those in the audience or who you know or that it might be over the age of 40. So presence of lumps and bumps and masses helps the patient to relax by offering instruction in deep breathing if that's helpful. It's really, really difficult to palpate a tense abdomen, so make sure their knees are bent and everything's as relaxed as it can be. So always palpate the tender areas last. So if they tell you they have right lower quad pain, then you're going to palpate every other region first before then, because they're not going to appreciate being in additional pain. Light. So you start with light palpation and then moderate and deep. These are the levels. So less than a ½ inch, no more than a centimeter. Moderate is a ½ inch to 3/4 inch, and deep is greater than 1 to 2 inches. Moderate and deep is not generally pleasant to the individual, so warn them in advance. This is a little bit deeper, and just that you're not going to be doing it all day long. You will need to know these numbers, so keep that in mind when you're studying. These are the parts of your hands that you use. You're going to make sure to use your fingertips, the index finger in particular, the thumb, your finger pads, nail tip. And then when you're assessing skin temperature, it's best to use the dorsum aspect so basically the back of the hand that has thinner skin, less moisture, and less blood supply, so your own body temperature doesn't interfere as much. The fingertips are best for assessing skin texture, for swelling and pulsation, and determining the presence of lumps. And if you've ever cut the tip of your finger, you know that that's a very sensitive area, so that's why those are the better ones to use for that. The base of the fingers, the metacarpal or phalangeal joints or ulnar surfaces. So here, the side of your hands, I'll make it in front of the camera. Here, that's the ulnar side here. That's the best for vibration because the bones are really close there to the surface and you can feel the vibrations better. Percussion. This will take time to really perfect for you, and I recommend that you perfect it. If you have longer nails, please cut them or trim them because I don't want you hurting yourself. But you're using your first 2 digits there and you're coming down on that middle finger. Let's see if I can get this here. So first 2 digits, this hand is flat against the surface. I like to put them together. You see in this particular demonstration they're a little apart. It's up to you. Just develop your technique and flick your wrist. Okay. You're going to use this when you're mapping out the size and location of an organ, the density, whether something's fluid or filled or solid, pain, and then DTRs, the deep tendon reflexes. You're going to have direct palpation or percussion, and then indirect. So you'll be able to see a difference in when you're working on this. And again, these are tools and skills you just need to spend some time learning. Watch the YouTube videos and really spend time learning. So direct percussion is used to assess the sinuses. Indirect is used to assess the lungs for resonance and the abdomen for tympany. Blunt percussion is really used to check for CVA tenderness. So here you go again. These are the characteristics of percussion noise. So the basic principle is that a structure is with relatively more air, such as lungs, produces a louder, deeper, longer sound. Think about that in terms of a drum, right? The drum is empty, it's full of air. Think about that, louder, deeper, longer sound. Vibrates freely. Whereas a denser, more solid structure, such as the liver, has a softer, higher, shorter sound because it does not vibrate, it's full. So just get that in your head as to if you're palpating something that should sound like a drum or something that should not sound like a drum. It's a little bit higher. So resonant noises are heard over normal lung tissue. Hyperresonant are heard over lungs that have an increased amount of air, such as emphysema. Tympanic noises are heard over the stomach and intestine. You can definitely do this to yourself, and you can hear those, especially if you're hungry or if you've just eaten, you can hear different levels of tympany. Dull noises are heard over dense organs like liver and spleen, and then flat are heard over thigh muscles, bone, or a tumor. So these are noises that you can try on yourself on different body parts and see the different characteristics and get a feel for them. Auscultation. So you have the bell and the diaphragm on your stethoscope. It is really important that you just invest in a good stethoscope. I still have the same one I had in nursing school. So it's lasted 20 something years at this point. So go ahead and invest in a good stethoscope because otherwise you're going to miss picking up murmurs. Never listen through clothing. And then you clean your stethoscope with alcohol between patients. Don't let it become a staphoscope, right? So clean it between. Indications. You're going to use the bell for low-pitched sounds, bruits, extra heart sounds, and murmurs. So the diaphragm, high-pitched sounds, breath, bow, normal heart. Okay? That's what you're using. The high-pitched sounds, breath. So bell is for the lower-pitched and the bruits. Bruit bell, right? And then diaphragm is really going to be using for those normal heart sounds, breath, bow, and high-pitched. So get that in your mind, how you're going to want to remember that. Legal and ethical issues. Promoting patient comfort is absolutely something we should be doing. Appropriate accompaniment, and then making sure you're explaining each step. Ease the patient into being touched. When you're assessing the thyroid, for example, I do not assess people's thyroid from behind them. You'll see it in your book about people coming from behind and assessing the thyroid. Some people, especially if they've ever been in any sort of abuse situation or have been strangled, or it's a bad idea to come from behind. So I usually go from in front and then palpate the thyroid that way, and you make sure that you talk to them about it. So appropriate accompaniment. Wow. For example, when you do a pelvic exam on a patient, another healthcare professional should be in the room. If you perform a pelvic by yourself and something later should be questioned, is your word against the patient's. So have somebody else in there. They don't need to be right up next to your cheek, so they don't have to be seeing the same thing you're seeing. It could be your medical assistant handing you the instruments that you need, but someone else needs to be in that room. Explain what you're doing with each part of the exam, especially when you're doing a procedure. When you're doing lidocaine injections, those hurt oftentimes much more than the actual suturing procedure. So make sure you tell them what's happening, and then ease the patient into being touched. So touching is a cultural issue. Brief touch on the arm, for instance, can orient the patient to pay attention, or pat in the arm can demonstrate sympathy. Some cultures do not like touching unless absolutely necessary. So the Navajo, for example, Hopi tribes, absolutely not. Others don't appreciate eye contact, and that can be something to be aware of. Draping, keeping your patient covered on the parts that you aren't looking at, keeping those parts from being exposed. So skin survey is the exception, and then they are going to need to be totally disrobed and one of those gowns put on so that you can be looking at different bits and pieces. Documentation, keep it factual. Document what you observe. Keep your emotion out of the medical record. It has no place there. Okay, toxicology. Two main categories, okay. Monitoring the concentration of therapeutic drugs like digoxin, lithium, etc., and then monitoring for abuse and environmental toxins. So therapeutic drugs, you'll need to know these particular levels here. And here we go. This is also just the standard toxology report in terms of what folks are seeing. So this one had a positive cocaine in the urine. So you can be looking at all different stuffs in here. This becomes important when you're doing pain contracts and you want to make sure the individual is taking the medication for pain, the barbiturate or benzo that you're giving them for that, or the opioid. Okay, here's your reasons for testing. So part of the pain contract, the opioid should be present, pre-employment, entry requirements, suspicion of drug abuse, sports participation, etc. And then here is the amount of detection past last drug use. Okay, these are the days. Look at the cannabinoid, right? The 20 to 30. Cocaine, 20 to similar, and opioids as well. So the key really is the DAT is the drug of abuse testing. Urine samples are used more frequently because they're less invasive, and you can, it's easier to collect, higher drug concentration, longer durations of detection. Okay, are all the drugs that can be abused in urine? No, it is not. It does not detect every possible drug, so something for you to be aware of. So yes, bath salts are hard, crystals hard, synthetic marijuana, synthetic meth is hard as well. False negative urine samples may be caused by if someone's using apple juice or urine from somebody else. Yes, the substitution or urine dilution. Masking, if they drink vinegar, it alters the urine pH. So, it's important to know. False positives can be a lab error if you have a hemp-containing food. This one's still interesting. Some people say eating poppy seed muffins or bagels can create a positive on a drug test for the poppy seeds and the opium. So be aware. And then, the following's a really good drug site on screening, and it's http://DIG.pharm.uic.edu/FAQ/2011/FAQ1.ASPX. So that is useful to be looking at. Okay, getting on into skin, hair, and nails. The skin, it's the largest organ we have, and it is our first layer of defense. It reflects our inner health, prevents and protects against penetration. It lets us know perception as well as temperature regulation. It allows you to feel touch, pain, temperature, pressure, for example. It absorbs and excretes. It has identification. Each of us have our own unique skin, so it has our unique combination of facial characteristics, hairs, color, and fingerprints. Communication. Blushing can be a signal of emotional state. Wound repair. It allows cell replacement of surface wounds. Synthesizing vitamin D. The surface of the skin is the surface on which UV light really converts cholesterol into vitamin D. Okay, you'll need to know these different levels, especially when you start talking about burns. Okay, so the stratum, this first one up here, that is that contains the dried keratin sites for protection, permeability, and it has various diseases that include the tinea versicolor, which is a fungal infection. So, and then the epidermis is right below that, right here on the side, a little pink. That's the cells and progression as follows. It goes from basal to spinous to granular levels. And then you will need to go over all these. The basement membrane zone those are the diseases of the bulbous pemphigoid, the herpes genitalicis, and systematic lupus as well. And then you get into the subcutaneous and the hair follicles. So know these and just get it in your head where the epi, so epi is on top, epidermis, dermis, subcutaneous. So epi, sub, epi on top, sub is below, like a subway, dermis is the main bit. So hopefully it'll help you a little bit. Oh, there you go too. So the epidermis is the outer layer, and then it's avascular. So this is when you can scrape, oh gosh, a little bit of the outer part of your skin and it doesn't bleed, right? And then the dermis is that supportive layer. That's where the blood vessels are. Okay. Subcutaneous, the fat cells, the insulation, the protection, upper layers with increased mobility, and has the keratin in it. Appendages, our hair, sebaceous glands, sweat glands, and nails. So two types of hair, the vellus hair, which is fine and faint, that's most of the body, that's usually on the arms and abdomen, for example, and terminal hair, which is the darker, thicker hair that grows on the scalp and eyebrows, and after puberty it can be found on the axilla, the pubic area, the face, and the chest of males. So hair growth is cyclical. There's active and resting. Each hair follicle functions independently, which is wild when you think about it. Some are growing, others are resting. That's why all your hair doesn't fall out and then you start over again, because it's all interwoven. Glands of the skin. You have sebaceous glands, the sebum, the sweat glands, the eccrine, and the apocrine, the thick milky secretions that happen. And that can be found everywhere except for the palms and the soles. So most abundant on the scalp, forehead, face, and chin. They produce the sebaceous glands produce a sebum, which is secreted through the hair follicles, and that lubricates the hair and skin, formulating an emulsion with water that prevents water loss from the skin. And then we have two types of the sweat glands, the eccrine, which is open directly into the skin surface and produces that dilute saline concentration called sweat. We are one of the few mammals that actually sweats all over our bodies, so that's an interesting fun fact for you. And the apocrine, so that's the thick milky secretion open to the hair follicles. They're mostly located in the axilla, the anogenital area, nipples, and navel. They become active during puberty, and secretion often occurs with emotional and sexual stimulation. And then our nail plate. We'll cover more of this, especially when you get into learning about having to do procedures with nails, but these are the different bits and pieces. So the laluna, and then the semilunar area, the proximal end of the nail, the cuticle, which covers and protects the nail matrix. Okay, macules. That is something that is flat, less than 1 centimeter. You will need to know these when you're going over and describing dermatologic lesions. So a primary skin lesion is intrinsic to the skin and not actually caused by any other pathology. Okay, so there's non-vascular and vascular types of primary lesions. So whether or not they're palpable or non-palpable, or if they can contain fluids or pustules. Macule, totally flat. You cannot, if you closed your eyes, you could not determine it was there. Patch is just a larger macule. It's greater than a side. Okay, I'm sorry, that's a papule. And then a plaque is a coalesced papule that can be uproofed to leave like denuded epithelium. So that's kind of like psoriasis. It can be an aggregation of papules. So papule, you can palpate it. Think of it that way. Patch is an macule, you cannot. Those are just color changes on flat skin. Papule, you can palpate. It's bigger. Plaque is a bigger papule, and they can actually be unroofed. Okay, plaques of psoriasis. You will see this, and you should know this. These are different pictures here that you can see. They're usually silvery, flaky appearance. Some changes to this type may also be seen in the hairline. So it's skin cells that multiply faster than up to 5 times faster than normal. So just the sheer volume causes those raised red plaques and covered in white scales. Usually occurs on the knees, the extensor surfaces. So knees, elbows, scalp. It can also affect the palm, the torso, the palms, and soles of the feet. Although it is treatable, it's not curable once people have that. Skin lesions, greater than a centimeter, but if it becomes larger, then it does become a nodule. Nodule is a solid elevated greater than 1 centimeter. If it is larger than a centimeter, it is called a tumor. A wheal is coalesced. If it's coalesced, it's called urticaria. So this is what hives looks like, right? Red, pale swelling of the skin occurs in groups on any part of the skin. You can have hives from salt water. You can have hives from cold weather. You can have hives from an allergic reaction. You can have hives from stress. Urticaria hives is something you can get from a lot of places and things. So they're usually puretic. They usually itch, but they can also burn or sting. Okay, hives. Here's what hives looks like. Confluent lesions that run together. Okay, so wheals that coalesce to form extensive reactions, intensely puretic. Not always. Your antihistamines are your best approach for these. I prefer the antihistamines that do not put people to sleep. So the Zyrtex, the Loratadine, the Claritin, those, Allegra, those are great for working with these. So these can be caused if people are having any sort of allergic reactions to foods, drugs, or infections. Sometimes this happens with insect bites and internal disease. Other causes can be just pressure, cold, or sunlight, like I said, or salt water. Okay, skin lesions, vesicle, filled with fluid. These are all fluid-filled primary skin lesions. Vesicle, bulla, pustule, a cyst. They vary in size. Vesicle is smaller than 0.5 centimeters. And a bulla is greater than 0.5 centimeters. Think of a blister with a bulla blister. Vesicles. Umbilicated vesicles usually have a central depression, and they're usually viral. Pustule, filled with pus, purulent matter. A furuncle is a large pustule. A carbuncle is a coalescing furuncle, usually scars after healing. Some people, unfortunately, have a lot of carbuncles and furuncles under their armpits. Cyst, an elevated, circumcised, encapsulated lesion located in the dermis or in the subcutaneous layer. Sometimes usually it's filled with liquid or semi-solid material. Oof, there's a picture. Sorry, it made a noise, scared me. Okay, that's a pustule right there. Okay, primary skin lesions, benign nevi. These are freckles. Okay, so symmetrical, round, oval shape, usually they have sharp defined borders, usually tan or brown. These are freckles. The technical name is benign nevus. Secondary lesions. These are your crust, your scale, your fissure, your erosion. There's your scale. Okay, so this is a change in a primary lesion. Crust, dyed serum, blood or purulent exudates, crust. So a scab, right? Slightly elevated, size varies, brown, red, black, tan, straw. Scale, heaped up, keratinized cell, flaky skin, irregular, thick, dry, or oily. A fissure, linear crack or break in the epidermis to the dermis, may be moist or dry. These happen with folks who have Raynaud's disease, and they get fissures and cracks in their fingertips, and they hurt. Erosions, you've probably had fissures from washing your hands too much in the wintertime, for example. Those can hurt. Erosions, loss of part of the epidermis, depressed, glistening, moist, following a rupture of a vesicle or a bulla. So if you have a blister that has burst, it can leave an erosion behind. Know this, love this. I didn't mean to click so fast. Go back and look at that one as well, but it's a nice little example of all the different types of skin lesions. Impetigo. Impetigo, you think honey crusted. You see under the poor kid's nose and on the corner of his mouth. This one's an impetigo secondary to chickenpox. You will probably rarely see this, as most individuals are now, oh my gosh, they've been giving vaccines against chickenpox. So you can see this. It is very contagious. Never touch lesions without gloves on. Fissure. So that's a finger, right? And just deep fissures, cold, like cracked, right? Ulcer, excoriation, scar, atrophic scars, lichenification. Lichenification is really when it becomes more like lichen is what it looks like, and then keloids. These are different types of scars effectively. So an ulcer is a deeper depression extending into the dermis. Irregular shape, may bleed, leaving a scar upon healing. So a stasis ulcer, a chancre, a pressure sore. Excoriation, self-inflicted abrasion. It's usually superficial. Insect bites, scabies, dermatitis, varicella, so chickenpox. A scar. So after the lesion is repaired, normal tissue is lost and replaced with connective tissue, the collagen, which is a permanent fibrotic change. So that's why you can see scars later. Atrophic scar. It's lost tissue. Scars from acne or surgical scars often are atrophic scars, a sunken formation signaling the loss of muscle or fat that supported the skin. Stria, like a stretch mark, are an example of that. Lichenification. Prolonged intense scratching will eventually thicken the skin, like lichen, and produce tightly packed sets of papules. It looks like the surface of the moss or lichen. Keloid, that's the hypertrophic scars. These are the skin is elevated by excess scar tissue. It's invasive beyond the site of the original injury. Higher incidence among highly pigmented ethnic groups, like Hispanics or African Americans. Vascular lesions, so these are the port wine stains that you usually appear on the face. They're birthmarks, strawberry mark, or some people call them a stork bite on the back of the neck. Hemangioma, a spider or star angioma, the venous lakes, the petechiae, the purpura, again, just based on where they are and how big they are. So non-palpable vascular lesions are the petechiae, the purpura, the tangelastic. So these are non-palpable. So, and again, depends on how big they are. The purpura are large diffuse petechiae, so greater than a centimeter. And the palpable ones may be, the origin is embolic or autoimmune or bacterial. That's usually really serious and needs to be taken care of. Angiomas, those are also hemangiomas. They're the same thing. They just have a little bit of blood vessels in it, so it blanches. If you're able to touch something again with gloves and it goes away, you can stretch the skin a little bit and goes away, you know it's in the dermis, and so it's therefore superficial. Venous lakes manifest as dark blue compressible papules called by dilation of venules. They were first described in 1956, and just for you to be aware of. Okay. Common shapes and configurations of lesions. Annular, circular, right? As in the anus, right? That's where that comes from, annular. So circular, benign in center, begin in the center and spreads to the periphery. The second one is a lesion described as a partial ring. Confluent means they run together, as in hives. You can have a discrete, you can have a grouped, a target, a linear, all sorts of fun bits and pieces there. So linear lesions of poison ivy. So poison ivy, you can see where the oils from the poison ivy actually touched. So it makes marks where leave the three, let them be, absolutely. Beware of poison ivy, oak, sumac. Close encounters can result in contact dermatitis that severe in cases may include pruritus, burning, weeping, blisters, takes up to 3 weeks. Unfortunately, yes, I know this as well. Fun fact, for those living in areas where mangoes grow, mangoes are related to poison ivy in that the mango sap, when you're, for example, catching fresh mangoes, can leave rashes like poison ivy. So not an issue for being for eating them at all. The sap is then dried, but for those that happen to be catching mangoes from trees, be careful. The culprit is the Yershwal, so oily, toxic, sap-like substance that is produced by these plants. It looks and appears like a shiny black lacquer when exposed to the air, which can be seen on the leaves of damaged plants. Sticks just about anything, including clothing, hiking, gardening, gloves, or pet hair. So it starts to penetrate the skin within 5 to 30 minutes. Rashes and blisters can appear 12 to 48 hours later and may last up to 1 to 3 weeks. It can remain toxic up to 5 years, so be aware. Wash those clothes you went hiking in. Someone can be exposed to this Urshawal without realizing it by petting a dog who's romped through a patch of poison ivy, for example, or burning wood, right? You've cleared some land, you're doing a burn patch, it can be aerosolized, and then that becomes a big hot mess for your lungs. Do not instruct your patients, do not scratch the itch, because under the bacteria under their fingernails can cause secondary infections. Treatments absolutely include oral prednisone. Okay. Yes, tell your patients not to itch these. The bacteria under their fingernails can cause other issues. Treatment includes oral prednisone, sometimes injected corticosteroids. Oral antihistamines help a lot. Still, oatmeal baths can help. Long sleeve shirts help prevent getting this on your skin, especially when you're gardening or hiking. Wash everything when you get back. Okay, don't burn the plants. That can be bad. Zoster, shingles, holy smokes. I believe we're going to see a time not too long from now where we won't see as many shingles, because as the folks who got vaccinated for chickenpox age, they're not going to get shingles, which is pretty great. So, but unfortunately right now there's a lot of folks who still can get shingles. So they are in a line along a nerve route, one side of the body. It is painful. It hurts. It is not subtle. And that's what they look like. So crusting over can take 3 to 4 weeks. They are contagious when they're open. So encourage your patients to keep them covered. If it is anywhere near their face, it is more of an urgent situation, because you do not want this anywhere near your eyes, because it can cause blindness. Unfortunately, from personal experience in my family, I know about this, so do not miss shingles on the head that looks like it's anywhere near the eye. It is an ocular emergency, so don't miss that. Okay, 50% occur in folks over 60, so make sure you offer your patients their zoster vaccine. Shingrix is one, Zostavax is another, so keep doing that. Okay. The virus can no longer spread once all the blisters are crusted over. Lesions arrange in a line. Like I said, shingles, it hurts, it hurts, it hurts, it hurts. Okay. Danger signs. This is the A, B, C, D, and E of your lesions that you see on skin. So if it's asymmetrical, if the border is irregular, if it varies in color, if the diameter is greater than 6 millimeters, elevation and enlargement, if it has changed, this is when their history becomes important. I want to show you something that I got off Amazon that I have now taped to where I go to my clinic site. So it is there we go. It's a wound care. It's probably hard to see, sorry. Let's try this. Yeah, so it's got a diameter. There we go. You can figure out how big your vessels are and your lesions by using something like this. So I just keep it with me, and it's got a ruler in both inches and in centimeters. So I just keep it with me. The other trick is to know on your body with your hands like how long something is. So for example, I know to my second digit here, or my second joint, that's about an inch. Okay, something. So just know that as you're working forward. Okay, malignant melanomas. Melanomas is less common than basal cell and squamous. It carries a much higher mortality rate, directly related to the depth of invasion. So identification is paramount to do this early. So especially if you've had a severe sunburn as a child, or your patient has, it increases the risk of developing melanoma. You do not want this. 4 types: superficial, nodular, lentigo, maligna, and acral lentiginous. And then They usually present as new moles or changes in existing moles, characterized by that asymmetric shape, irregular borders, variation color, greater than 6 millimeters. So excessive exposure to UV radiation from sunlight, absolutely. Location is mostly on the upper backs of men and women or on the legs of women. It can be anywhere though. Prevention, use sunblock. Higher than 50, really. 50 is the best one you should be using. Tell them to put sunscreen on their children, absolutely. So the most common is that superficial. So be aware of that. Immediately surgical removal may include chemo if it has progressed. Okay, basal cell. This is a basal cell carcinoma of the eyelid. Ouch, right? So is the most common type. Basal is the most common type, a nodular ulcerative. So there it looks like it's forming an ulcer with raised, rolled, or whitish borders. And then it can have crusting can occur. Lesions are mostly on the head and neck. If pigmented, a basal cell carcinoma may be confused with a melanoma. Still, make friends with your local dermatologist and get them in. Small bumps, smooth or waxy, whitish to pink, may resemble a pimple but fail to clear up after a few weeks. They usually become an ulcer or sore as they grow, mostly on the sun-exposed areas, so the face, neck, back, arms, or legs, especially in fair-skinned individuals. So Fitzpatrick 1 to 2. Instruct your patients to avoid unprotected sun exposure. And sun SPF factor says 15 in your notes here, but it really should be 50. And then 95% cure rate with surgical removal. Squamous cell carcinoma, second most common skin cancer. Usually begins and is confined to the epidermis for a time, has a high cure rate, but can cause disfigurement or even death if it's neglected. Commonly characteristic is a bleeding or non-healing sore, a reddish patch or a wart-like growth. It can appear as scaly, crusty wart as a bump. And then it's a slow-growing cancer people who have regular exposure to sunlight. Okay. People who have fair skin, blonde, red hair, blue, green, gray eyes have higher risk than average. Located usually on the ear, face, lips, and mouth. And then again, wear sunscreen. Okay. AKs, actinic keratosis. These look like the stuck-on patches, especially in older individuals. They are precursors to squamous cell cancer. Do not get confused with subarachnoid keratosis. The AKs and the squamous cell carcinomas represent the same disease process at different levels. So these can typically be treated with cryotherapy. Okay. These are what you should be asking your patients. So are they outside? Do they work in a garden? Do they have any change in color or pigmentation? Medication, sulfasalazine, makes people more susceptible to sunburn. Assessment, inspect and palpate, and then you want to keep the patient draped. Look at the color, moisture, temperature, etc. Okay, we already talked about the different parts of the hand. Use the dorsum, back of your hand, thinner skin. Developmental considerations, you want to look at those hair follicles at 3 months gestation, the lanugo, which is that fine downy hair of newborns, and the remixed cassovia. I'm not saying that quite right. I'm gonna let one of y'all figure out better how to say that, but it's that thick, cheesy substance of little babes. Okay, the Mongolian spot. These are not something to be confused with bruising. Okay, that Mongolian spot can look like bruising. It's typically at the back of the neck. You'll see it in individuals with darker skin, Hispanic individuals, as well as African Americans. The capiole spot, if it's less than 6 centimeters, it's normal. So just know this stuff here. So the erythema toxicum is something you should be aware of, and the harlequin color change as well. Typically, infants will have a beefy red flush for the first 24 hours. And then sometimes they will have that mottled appearance in the child's chest, arms, and legs if they have the cutis marmorta. Okay, physiologic jaundice. Um, the child needs to be next to some UV lights. It can be windows or it can be in the hospital depending on how severe it is. There's the stork bite again and the vernix. Okay, when you're talking, you want to make sure if the individual has any infants, or if the infant or child has any birthmarks, introduction to new food or formula, diaper rash, burns, bruises, etc., sun exposure. This is the vernix, that area in between the neck and the shoulders. It's that cheesy like substance. Meigolein spots you see all around this individual's bottom and on their side. It can look like a bruise. It is not. Make sure you document the size and location. It can be mistaken for child abuse, so be aware. Here's the erythema toxicum and what that looks like. Okay. This is when it may be normal in the first few hours, so the limbs, the exterior bits of the babe, is blue-like. It's due to sluggish circulation, the blood through the peripheral structures. So it's normal if it disappears in the next day or so. Otherwise, it needs to have better attention. This is that mottled appearance. So it's common in newborns, alternating areas of dilated constricted blood vessels. So again, just to be aware. There's the mila, the little white bumps, right? They're benign, self-limiting, may manifest as tiny white bumps on the upper forehead, nose, and upper lip of the cheek of the newborn. Okay, many skin changes are associated with pregnancy, and you'll see the mask of pregnancy, the chloasma, the melasma, and then areas of hyperpigmentation on the skin, usually on the face. Skin tags may increase in number, especially on the upper trunk. Other changes in pigmentation include the linear alba, usually resolves after pregnancy, and then the cherry angiomas, darkening of the areola, and any pre-existing nevi might darken as well, and then stretch marks as well. Okay, this is that mask of pregnancy. This is a severe area or a severe case of it where it extends beyond just the cheeks. You see it above the lips and on the ends of the cheeks as well, or the cheek. Yeah, very sensitive to sunlight. It'll darken with exposure. So again, use sunblock. How about some more sunblock with your sunblock, right? These are the skin tags. Okay. You can refer to derm, or you can try to freeze them off if they don't have many, if they're not vascularized. So in aging, the aging adult, you're going to have decreased lacticity, the senile purpura, the senile legintitis, the liver spots, the seborrheic keratosis, skin tags, the hyperplasia, the increased risk for skin disease and breakdown, and then a change in hair distribution. My grandfather would always say the hair is leaving the places you want, like the top of his head, and going to the places that you don't want, like his ears. So something to work or think about. So you want to ask about skin changes, delayed wound healing, any skin pain, changes in feet or toenails. Okay, these are the senile purpura, new lesions. They look like bruises, so be aware. And a lot of our older folks are on blood thinners, so be aware. Here's the seborrheic keratosis, area of pigmented raised warty lesions, look greasy, dark, kind of stuck on. Those do not become cancerous. Okay, this is a yellow crumbling nail. It is a fungal infection. Half of all nail disorders are caused by the onychochromiasis, and it's the most common nail disease. Toenails are much more likely. It's increasing and related to diabetes, a suppressed immune system, and increased age. Okay, you see this toenail is not where it's supposed to be. That's uneven, improper pressure on the nail bed, promoting the downward bending of the toenail. Major cause are poorly fitting shoes or improperly cutting the toes. This should never have happened with somebody who is getting regular foot care, because that is going to take a lot to take care of. So just be aware. The nail can also grow outward when the skin into the skin when you cut off the corners and trim them too short. Ingrown toenails occur when the nail is too big for the toe or it thickens. So to prevent ingrown toenails, wear properly fitting shoes and trim nails straight across without tapering the edges. To treat an ingrown toenail, soak the area in the foot for warm water 15-20 minutes. Push down dry absorbent cotton under the corner nail. Be sure to change that cotton frequently. You might need a minor surgery to remove the ingrown toenail as well. Okay, perionychia. These are infections of the finger in particular, right along that nail bed here. It is paronychia, it's the most common hand infection, and if left untreated can progress to more severe infection of the entire finger or toe. I've saw this a lot working with bartenders and whatnot, those that pick up all the drinks, like 10 drinks with their fingers like that. Never do that. That is a really good way to get an infection because you're putting your hand in where people had their mouths. So it can also happen by damage to the nail. So nail biting, thumb sucking, dishwashing, chemical irritants, also caused by fungus. So be aware. There's lots of ways this could be caused, but usually it's staph. Okay, normal versus clubbing. You see the curving on the clubbing? That can be attributed to a lack of oxygen circulation. Can be hereditary. It can also be caused by cardiac or pulmonary disease. In children, it can be caused by cyanotic congenital heart disease, cystic fibrosis, and inflammatory bowel disease. Assessment. Remember, for the skin, hair, and nails assessment, we use inspection and palpation to complete physical exam. Observe the skin overall. You want to focus on color, moisture, texture, turgor, and temperature. Look for areas of damage. Look for skin that splits or cracks easily. Look for localized areas of bruising, cyanosis. Check for uniformity and color variations. Okay, moisture. Check and see if the individual has good turgor. So with the turgor, you take their skin and you watch it bounce back. I have pretty good turgor right now. I've been hydrating. So those that have less turgor, their skin's going to stay tinted for longer than those that are more hydrated. Skin check. There's your turgor right there. Inspect and palpate with skin texture, noting thickness and mobility. You want to look at all the different areas of it. So squeeze the skin. You can do the forearm. You can do the back of the hand. That's fine. With older individuals, decreased elasticity in the skin, best to check in the sternal area because of decreased elasticity. You're going to have a hard time doing that with some individuals, so try the forearm first. So use the dorsum surface of your hand and then to check for skin temperature. Okay, this is checking turgor right here. Okay, and again turgor. Testing, tinting, that's when that individual needs more fluids, I can tell you that right now. All right, rating edema. 1+, mild pitting, moderate pitting, deep, and very deep. Okay, localized areas of tissue necrosis develops when soft tissue is compressed by a bony prominence for long periods of time. So this is why you want to get folks up and moving. You can have, this is the etiology of the pressure ulcers, from pressure, friction, shearing, and moisture. Okay, ischemia, pressure, cell necrosis, sloughing. All the different red spots are places where pressure ulcers can happen. Those are pressure points. So if people are using wheelchairs, etc., tailbone is a big area. Shoulder blades, confined to a bed, it's going to be the back and side of the head, the rim of the ears. So this is why we turn our patients every 2 hours. Staging pressure ulcers. Stage 1, non-blanchable erythema and tacked skin. Okay, so if you touch it and it does not blanch, that's non-blanchable erythema. So that's the beginning stage. The site might be painful, firm, soft, warmer, or cooler. Stage 2, it's an open wound at this point. The outer layer, the epidermis, and part of the underlayer of skin, the dermis, is damaged or lost. It's shallow. That appears as a pinkish red basin-like wound. May appear as an intact or ruptured fluid-filled vessel. Stage 3, deep wound. Loss of skin usually exposes some amount of fat, has a crater-like appearance. Bottom of the wound may have some yellowish dead tissue, slough, and the damage may be extending beyond the primary wound. Stage 4, large-scale loss. exposed muscle, bone, and tendons. The bottom of the wound contains slough, dark, crusty, dead tissue, the eschar, and then lots of further damage. Braden scale, so you're going to look at that sensory perception, moisture, activity, the mobility, nutrition, and friction. So that is the predicting the pressure sore risk, clinically validated tool. So get to know how to use that as well. Pressure relief devices, skincare, incontinence care, activity, nutrition, and prevention by turning them over, right? A wound will eventually regain approximately 80% of normal tissue strength. It will never regain 100% of pre-wound. So know that. Systematic factors, these shouldn't be terribly surprising with age, chronic disease, vascular insufficiencies, immunosuppression, nutritional status, anemia, medications, infections, and different issues with the blood. And holy smokes, y'all, you made it. Good job. Till next time.